that door, and we need to exit fairly quickly because they're cleaning the carpets in prep for the art visit next week. So, just a reminder of that. I think Jan is going to come back. Okay. So, was there really no like Wi-Fi glitches or frozen browsers at all today? Oh my gosh. So the only thing wrong was my whacked out wording on that one question.
Don't jinx it.
All right, well, what a nice gift for today. Okay, so remember last time we had a bit of confusion about some of the veins of the upper limb, so we're going to revisit that and hash out the details today.
Dr. Burton?
Yeah.
And that one in the middle, how that one demonstrates it there as I'm looking at this PowerPoint, is exactly how I would have learned it, because it's axillary deep vein to brachial speed.
Right.
So, but yeah, that picture on page 721 hopefully makes it.
Yep.
So.
Yeah, exactly right. So, yeah, if you look at 721, you'll see that your book shows the basilic vein as the predominant vein and two little itty bitty brachial veins coming in. So really, what matters is the basilic vein and the brachial vein come together to form the axillary vein. Okay? Where it does that, whether the basilic vein is larger, which it typically is, or the brachial is a little bit more prominent, is inter-individual variation. Remember, with the veins, we have a variation all over the place. They basically do what they want. And so we'll have several different images, and often, you'll see just a kind of almost equal size between the two. So between every anatomy textbook I looked at on Wednesday afternoon, because I was like, what the heck? Every single one of them showed it slightly differently. So what it really matters is we have a brachial vein, which is usually a joining together of a lot of smaller brachial veins, because there's two brachial veins that go on either side of the brachial artery. Remember our paired veins for each artery. And we have a basilic vein, and there's a basilic vein right there. They come together to form the axillary vein. That is the story that is important. Whether you talk about the basilic vein as a continuation of the axillary vein or the brachial veins as a continuation of the axillary vein, but it depends on who you talk to and how they learned it. So, joy of anatomy, nobody can agree. Yeah, questions?
So, the brachial is deep.
Mm-hmm.
Okay. And then the basilic is the superficial.
Correct.
Okay.
Yep.
Along with the symbolic, but I was just going to say, I think that's really the only thing that you can be 100% positive is deep veins or maybe an axillary, brachial ulnar, superficial or cephalic basilic.
Exactly. Yeah. So that is what we really need to know. Other than that, let the variation happen. All right. Okay. Does that make more sense now? Excellent. All right, so let's go through some of the bony structure and joints of the upper limb. So start off fairly easily, the clavicle. We're all familiar with that. This is the most frequently broken bone in the body. So it can be broken often in cyclists, so I'm just waiting for the day when mine finally gets broken. Lots of different accidents. A few surfaces and features I want you to know. Obviously, the articulating facet with the sternum, the articulating facet with the acromion. And then the two surface features I want you to know are the trapezoid line and the conoid line, tubercle. And these are important attachment sites for ligaments between the joint between the acromion and the clavicle. Okay. So clavicles, pretty easy. All right, the scapula. Is it really that? What happens in the quality of my? There we go. I can't even read it on these things. Okay, so on the scapula, we want you to know the major surfaces. So the anterior surface is the subscapular fossa. And we have two surfaces on the posterior side, the infraspinous fossa and the supraspinous fossa. These are important because lots of muscle attachment occurs there. Between the two posterior surfaces, we have the scapular spine here. It's that ridge, again, important for muscle attachment, widens out to join with the acromion here. And the acromion is that bone that actually forms the palpable tip of the shoulder. And then the articulating surface of the scapula with the humerus is the glenoid cavity. And finally, we have the coracoid process. This is a process that's important for ligament and muscle attachment. Kind of a protrusion out anteriorly and laterally from the body of the scapula. All right. Next is the proximal humerus. You can almost read it on this one. Obviously, we have the head that articulates with the glenoid cavity. We have two necks. We have the anatomical neck, which is what we would normally think of as the neck of a long bone, so just distal to the head. Then we also have the surgical neck. The surgical neck is below the major tubercles of the proximal humerus. This is a location when it's fractured, often needs surgical repair. Which is why it gets its name. So when we're talking about a humeral neck fracture, it's typically talking about this surgical neck rather than the actual anatomical neck. When it's an anatomical neck fracture, they actually specify that it is anatomical neck. Just, to make it more confusing. All right, I do want you to know the greater tubercle, the lesser tubercle, and the groove between them, the intertubercular sulcus. So tubercles, as we've learned, are important muscle and ligament attachment sites. Several of the important muscles and tendons attached there, including rotator cuff. And then also we have the deltoid tuberosity, which is the attachment for the deltoid. Okay, so that's the humerus. All right, so some joints that are important. So the sternoclavicular joint, it's a synovial joint between, that's an A, the proximal clavicle and the manubrium of the sternum. It's actually a pretty stable joint, so it's very rarely dislocated. That's about all you need to know on that. Okay, acromioclavicular joints. Again, the joint between the acromion and the clavicle. This is where we have the coracoid process, tubercle, and the trapezoid line come into play. So here's the acromion here coming up here. Between the acromion and the clavicle is the acromioclavicular ligament. And then stabilizing the more lateral portion of the joint is the coracoclavicular ligament, which is composed of the trapezoid ligament and the conoid ligament. As their names imply, the conoid ligament attaches to the conoid tubercle, and the trapezoid ligament attaches to the trapezoid line. Okay. So, acromioclavicular joint. Okay, so like we said, the clavicle is one of the most commonly fractured bones in the body. So here we see a nice displaced clavicular fracture. Often when the fracture is complete and we have displacement, we have the medial portion moving superiorly and the distal portion moving inferiorly. Why would that be? Any ideas? Why would this distal part? Yep. So right here, we have tension from the sternocleidomastoid muscle. Okay, so that pulls the medial part forward. And then we've got the two
Forward or
Superior.
superior.
Or how does what?
Yeah, thank you. Superior. Oh my gosh. Okay. And so then we have the distal part of the bone pulled inferiorly by those coracoid. Oh, what the heck is the name of them again? Wow, my brain. Corticoclavicular ligaments. Okay. Another note, typically the most commonly fractured portion of the clavicle is the middle third, especially at the borders of that middle third with the distal and proximal third. Okay? For some reason, the distal and proximal thirds of the bone are not as vulnerable to fracture. Okay?
Can you say that last part again?
Yeah, so the fractures typically occur in the middle third of the clavicle.
Closer to the sternum?
No, just like right in between.
Oh, the middle, okay.
Yeah, so
gotcha.
the middle third. So if we divide it into thirds, we have like there and there. So we
Gotcha.
see fractures happen more often in this region. Very, very commonly, they happen right at the borders of the thirds.
Okay.
All right, any other questions? No? Okay. All right, then the next problem we could have in this region is shoulder separation. So this is a dislocation of the acromioclavicular joint. Okay. There are several different types depending on how severe they are. So if it's just a minor tear of the acromioclavicular ligament, so partial damage, that would be a type 1. You have complete damage to the acromioclavicular ligament and partial damage to the corticoclavicular ligament. That's a type 2. And then we have complete rupture of both of those. That's a type 3. Okay, and then typically, instead of seeing a very close association between the acromion and the clavicle, we'll see superior medial displacement of the clavicle.
With the severe one.
Sorry?
What did you say the last part? Superior medial displacement with what?
Of the distal portion of the clavicle. So up and it just kind of
With type 3?
moves up, yeah. But the amount of separation will depend on the severity of the injury, so. Okay, any questions? Okay. All right, so then the shoulder joint itself. So as we know, the glenoid cavity is basically the socket of the joint. Surrounding the glenoid cavity is a fibrocartilage structure. Called the glenoid labrum. And it basically just extends out from the lip of that glenoid cavity and increases the surface area of that socket. So here we have a radiograph of the shoulder joint, a normal shoulder joint, and since cartilage isn't going to show up as well, just drawing kind of just a small increase in the extent of that cavity, all the way around. Okay. One structure that passes through this joint area is the tendon of the long head of the biceps brachii muscle, to where it attaches here on the superior surface, just outside of the glenoid cavity. And so that transverse humeral ligament kind of keeps that tendon in the wow, words are not coming today, tubercular sulcus. So here we have the tendon running in the tubercular sulcus, wow, and the transverse humeral ligament kind of keeping it in place, okay? So also note the smooth contours here of the normal shoulder joint and close association between the different structures. Okay. So like most of the large joints of the body, is the synovial joint. So we have our synovial membrane, and then outside of the synovial membrane, the fibrous membrane of the joint capsule. And those together make up the joint capsule. So just remember that that is present. There's this extra little synovial sheath around the tendon of the biceps brachii long head. This just shows the complete intact joint capsule there. Okay. All right, so dislocations of the shoulder joint. Most commonly, they're anterior, and then a subsequent inferior movement. Okay, so they slip out anteriorly and then they pass down to the inferior portion of the glenoid cavity. Excuse me. This is most often happens when the arm is extended and abducted and is it laterally rotated? Yes, laterally rotated, and then there's a blow to the arm. So this kind of putting that extra force on that joint. Because the glenoid cavity and the glenoid labrum are fairly shallow, this is a joint that's very susceptible to dislocation. And once it's dislocated, it's incredibly high risk of recurrent dislocation. So up to 90% sometimes. Often you also have fracture of the glenoid cavity, the lip of the glenoid cavity, and a tear of the glenoid labrum, which adds pain to the injury, and further destabilizes the joint in the future. Because of this movement down and anteriorly, this part of the humerus can do a couple of things in nerve damage. So because, remember, the axillary nerve wraps around the surgical neck of the humerus, the movement inferiorly and anteriorly can actually put pressure on the axillary nerve and cause axillary nerve damage. We also can have stretching of the radial nerve, and also that would also then obviously incur nerve damage. So you can have some loss of sensation and motor control. Often that, if it's not too severe, can repair. Peripheral nerves do have the ability to repair themselves. Okay.
What did you say often gets fractured?
So you also often get fractures of the lip of the glenoid cavity, and then tears to the glenoid labrum, because you're pulling it out over that lip in there. Not the most sturdy bones on the planet. Okay. Any other questions? No? Okay. So then, remember the rotator cuff, and we had the four muscles that are composed, the muscles that contribute their tendons to the rotator cuff. There's a mnemonic to help you remember, SITS, sits, for supraspinatus, infraspinatus, teres minor, and subscapularis. The supraspinatus and infraspinatus originate on the posterior surface of the scapula in those fossa that have corresponding names to them. The teres minor inserts on the lateral edge of the scapula, and the subscapularis inserts on the subscapular fossa. And then they all insert around the the tubercles and the anatomical neck of the humerus. So what I do want you to know about their location of insertions is just which quadrant they're in, basically. So our supraspinatus ligament is going to be on the superior aspect, and this is one of, when this is torn, this is one of the ones that causes the most pain, because inflammation in it is actually restricted because the tendon is located between the head of the humerus and the acromion, so it has limited space to swell. We also have the subacromial bursa that also can get inflamed as it's associated with the supraspinatus ligament. Okay. As we move posteriorly, we have the infraspinatus and the teres minor on the posterior region. And then anteriorly, we have the subscapularis. Oops, here. Okay. Like I said, they can get torn, and that just causes inflammation and swelling in the area, and it's rather painful, I'm told. Another note about the supraspinatus muscle, this is the one like what Dr. Carlson was saying initiates abduction. That first few degrees of abduction before the deltoid and other major muscles can take over. So that's the supraspinatus there. All right, so here's a MRI. We can see here the head of the humerus, and we see the various rotator cuff ligaments around it. So supraspinatus there, infraspinatus, teres minor, and subscapularis wrapped around there. Excuse me. And so then contraction of the muscles associated with those rotator cuff tendons is going to do what? Do you remember? So it's going to pull the head of the humerus into that glenoid cavity. That's the whole function of the rotator cuff, is to prevent dislocation by pulling the two halves of that joint together.
So it actually does what?
It pulls the head of the humerus into the glenoid fossa, or glenoid cavity. So then, when there's a tear, not only are we causing lots of inflammation, but we're potentially reducing the strength of that mechanism, maintaining the integrity of that joint. So here they show a tear. So here's the supraspinatus tendon coming through here. Instead of being of a uniform color, so we see some abnormalities in the color there, indicating the tear and the associated inflammation. So then treatment, so this is an ultrasound of the supraspinatus. So here's the head of the humerus down here, the bursa. And so to help control inflammation, they'll insert the needle and inject typically a steroid, so probably corticosteroid. And sometimes also an anesthetic to help control the inflammation and the pain, to allow that tendon to heal a little bit more easily and reduce discomfort. Okay, any questions? All right, if there's no questions, have a wonderful weekend, and please exit out to that lovely door over there.
Oh, shit. Grow a few cultures over the weekend.
Yeah.
What do you think really? Or what? I mean, we could present, I say So, what do you think is here?
The weekend. So excited.
Yeah, you too. See something.
Good luck driving